first talk. Dr. Harshul. The Galaxy Era, Redefining Presbyopia Correction with Rayner RayO. Dr. Harshul.
Thank you so much to AIS for giving me this wonderful opportunity. And I'll be speaking on a very recent advancement in IOL technology, which we have got now. That's the RayOne Galaxy Spiral IOL. We all know that for years we have been using diffractive presbyopia correcting IOL to give full range of vision to our patients. But the main problem with these diffractive kind of lenses is of dysphotopsia, that is glare and halo, and of course we lose contrast sensitivity. So these are two main problems in diffractive design, which has been taken care by the world's first spiral IOL that is introduced by Rayner. That's the Galaxy IOL, and it's focusing on full range of vision to our patients from distance to near with less halo. So we all know that we can't cheat with optics. Of course, if we are getting something, we tend to lose something. But with the spiral optics, the halos is minimized so much that literally almost 70-80% of patients don't report them, and even those patients who have, they have very mild halos which gets adapted over time. So this new Galaxy IOL delivers full range of vision with minimized dysphotopsia, which is just comparable to enhanced monofocal or monofocal plus lenses, which is achieved through this refractive optics which is there. And it's also available in toric powers, and we all know that the acryl hydrophilic acrylic material is time tested and over 12 million has been implanted. And now very soon it's going to come in hydrophobic platform also. And it's available in power range from 5 to 30 diopters with 0.5 diopter increment, and toric power is also, toric lenses are also available from +6 to +30 diopters. So let's see that how the optics are. So if you see the surface construction of this particular IOL, you can see that it's made of different component. This is the far. So central 1.1 millimeter of area is for distance. It's not changed, but the holy grail is in the 1.1 to 3.3 millimeter of the optic zone, and after that again it becomes normal lens. So because of this 1.1 to 3.2 millimeter zone, there are spiral optics which is there, and it is the first IOL which is designed with artificial intelligence, which creates a unique spiral pattern for optimal patient outcomes. And this spiral pattern, it allows, you can see here this the defocus curve. It allows continuous variance of power, which focuses light at every position along the defocus curve, and it results in precise control of optical power from far to the near, and it produces, the best part is there are no bumps. It produces a continuous and smoothly changing surface, and there is a smooth and continuous full range of vision which is available to patient. So have a look at the defocus curve of this IOL. So we can see that till minus 2.5 minus 2.8 centimeter, there is a continuous defocus curve which is more than 0.2 log MR, which is equivalent to 2032. And if we have a look at the defocus curve of, this is black is the defocus curve of Galaxy IOL, and this blue is for trifocal lenses. So you can see that this is the continuous, and especially from far to intermediate, and this curve is higher, and of course it's smoother than trifocal lenses. Again, this is the graph which compares binocular and monocular defocus curve. Intraoperative, when we see, you can see there's a trifocal lens. We can see all these diffractive rings which are there in trifocal lens. Whereas in this lens, if you tell patient to look into light, you will hardly see some undulations there, the spiral optics which is there. So there's a very smooth surface. And this is the vision simulator which study was done comparing halos and glare. On this left side is with the spiral galaxy IOL. On the right side is with the panoptics IOL. You can see the size and intensity of halo is very less as compared to the panoptics trifocal IOL. So this is the video which shows the implantation. It comes in the preloaded injector system. So you just have to put, okay. So there's a hole there, just like Rayner other preloaded lenses. So you just put some OVD or BSS there, close this cartridge, and this is the hydroimplantation technique. Just put irrigation cannula there, and it goes through 2.2 millimeter incision. See there, you can't see any rings there. The surface is so smooth. So in the end, after, if you tell patient to look in light, you'll see some spiral things which are there. See, when I tell patient to look on different sides, you will see some reflexes which are there. So coming to the patient selection and counseling, it's going to be same as of for any trifocal patients, but we need to tell them that they may see some halo, but they'll go away with time. There'll be very little dysphotopsia, I think. So in the paucity of time, I think I'll come to conclusion that so this is the world's first spiral IOL which is designed with AI to deliver full range of vision with minimized dysphotopsia. And as you saw, intraoperative image suggests smooth optic surface without step, discontinuities, or discrete annular rings. It gives excellent binocular vision at all distances. And we saw clinical binocular defocus curve which showed full range of vision extension with smooth plateau between plus 0.5 to minus 2.5 of defocus. There is reduced halo and glare in the vision simulator test for Galaxy compared to diffractive trifocal lenses. It's also available in toric powers. Thank you very much.
Dr. Harshul,
Yes, Dr. Allen.
how is this spiral different from the other read-off lenses, technology-wise?
So it's a patented technology, as I said, that the same technique of spiral technology is also used in contact lenses also to give, So this gives smooth vision from distance to near as compared to rings, which gives 3 focal point, like, in trifocal we have 3 focal point, but there is a bump dip down in between. But because of this spiral technology, there is a continuous range of vision and there is no dip. So patient have a very good vision. And because of the smooth surface, halos and glares, they are also very less dysphotopsia. We can't get away with dysphotopsias at all, but they are less as compared to the
Trifocal.
Yeah.
Thank you.
Differs from synergy. It will also, they also say continuous vision.
Yeah, it
Synergy
gives,
and-
but dysphotopsia is a problem, sir. Now more and more we are moving towards the optics, which gives us less dysphotopsias. They give excellent near vision, intermediate vision, and this. But if you see the continuous range, you see this defocus curve tells us how a lens is performing. So defocus curve tells us everything. So good vision at near, intermediate is fine, but If we talk of continuous range, so slowly and slowly we all lenses, optics, they are improving to a point where we can, simulate a natural, what young people have, that kind of vision.
Refractive
Yeah, it's a combination of read off and, yeah, yes.
not a refractive.
Near.
That is diffractive.
So only thing I'll tell everyone is to be careful of the A constant. It's light quite different, so you need to be very careful. In one patient I had minus 0.75, so A constant you need to stick to what the manufacturer says. Yeah.
Good morning, sir.
Yeah,
Nice
hi.
talk, Dr. Harshul. Sir, dysphotopsias not only depend on the rings, but also on the refractive index of the lens. So, and negative dysphotopsia will happen with any lens because it is properly implanted in the bag. Basically, that negative dysphotopsias we can't reduce. It's basically positive dysphotopsias like glare,
Yeah, yeah,
halos, and
of course.
starburst.
Of course.
But they also depend. So, what is the refractive index of this lens, sir?
Refractive index, I'm not sure.
Because
I don't
mostly
remember
it
the
is,
refractive
if it is
index.
hydrophobic aisle, then acrylic hydrophobic aisles have the maximum number of dysphotopsias, then silicone aisles, then last acrylic hydrophilic aisles,
Yeah.
because of the reduced refractive index in hydrophilic aisles. Yes.
Yeah.
Yes, ma'am. Yes, ma'am. In some studies, ma'am, in some studies, it has been said that we place it temporarily, the optic haptic junction, that tends to reduce negative dysphotopsia. But
So mechanism
So
of
inferior
negative
temporal.
dysphotopsia is totally different. We are talking of positive
positive
dysphotopsia.
dysphotopsia,
Yeah.
basically.
Yes.
Exactly.